Hello everyone, this is Dr. Mushfiq Tarafdar. I'm an epidemiologist and an associate professor at the Geisinger Commonwealth School of Medicine. In this lecture, we'll learn about basics of infectious disease transmission dynamics. The overarching goal here is to provide you with some fundamental knowledge of infectious disease epidemiology and to set the stage for the next lecture, which will primarily be about mathematical modeling of person-to-person transmission of infections. Although this lecture is not specifically about SARS-CoV-2 or COVID-19, I will be using SARS-CoV-2 as an example wherever applicable and appropriate. Standard copyright and disclosure. All materials found on GCSOM's course and project sites may be subject to copyright protection and may be restricted from further dissemination, retention, or copying. Disclosure, I have no current financial relationship with a commercial entity relevant to this educational material. At the end of this lecture, you'll be able to define epidemic and pandemic. You'll be able to discuss characteristics of microbial agent, host, and environmental factors that are pertinent to infectious disease epidemiology. You'll be able to describe the routes of infectious disease transmission. You'll be able to define attack rate, case fatality rate, and cause-specific mortality rate. You'll be able to talk about incubation, latent, infectious, and symptomatic periods. You'll be able to define herd immunity and basic reproduction number, which is denoted by R0. And you'll be able to discuss the importance of R0 in relation to the spread of infection and herd immunity. We'll start with two public health terms, epidemic and pandemic, which in this era of COVID-19, we hear quite frequently. But how are they actually defined? When the occurrence of cases in a defined community or region exceeds what is normally expected in that population during a specified time, then we call it an epidemic. To know what frequency is clearly in excess of normal expectancy, we first need to know what is normal, what is expected. For that, we get help from disease surveillance systems. Disease surveillance tells us what is normal for a particular population at a given time. Based on that normal or expected frequency of cases, an epidemic threshold level is determined. When the number of cases crosses that threshold, that's when we have an epidemic. Pandemic, on the other hand, is defined as an epidemic occurring worldwide or over a very wide area, crossing international boundaries, and usually affecting a large number of people. This definition has at least a little bit of vagueness in it. What do we really mean by worldwide occurrence or occurrence over a very wide area? Does crossing international boundaries mean the infection needs to spread from one country to just one other country? This vagueness may have contributed to the confusion or lack of consensus about the timing when COVID-19 actually became a pandemic. Next, I'll briefly talk about one of the multiple causality models, the epidemiologic triangle model that is often used to explain etiology of infectious diseases. This model recognizes three major factors in the causation and transmission of infectious diseases. These three factors are agent, host, and environment. Agent in case of infectious diseases is a microbe. On this slide, we have a few important characteristics of agent, host, and environment that pertain to infectious disease epidemiology and transmission of infection. Infectivity is an agent factor, and it refers to the capacity of the agent to enter and multiply in a susceptible host and thus produce infection or disease. In epidemiology, secondary attack rate is used to measure infectivity. We'll learn a bit more about secondary attack rate in the next couple of slides. Virulence, another agent factor, refers to an agent's capacity to induce disease in the host. If the disease is fatal, virulence can be measured by the case fatality rate. Antigenicity refers to the ability of the agent to induce antibody production in the host. The host counterpart of this agent characteristic is host's ability to develop immunity against a specific disease. Finally, physical, biologic, and social environment can play a role in the causation and transmission of infectious diseases. Particularly noteworthy here in relation to transmission of SARS-CoV-2 is social environment, which includes behavioral, personality, and cultural characteristics. These characteristics often determine the frequency of social interactions and contact between infected and uninfected but susceptible individuals. Secondary attack rate measures the spread of a disease within a circumscribed unit, for example, a household, a dorm, a military barracks. It's a measure of contagiousness or infectivity. This is how we calculate secondary attack rate. In the numerator, we have the new cases in the circumscribed unit minus the initial cases. In the denominator, we have all the susceptible individuals in that same unit minus the initial cases. Now, who are these initial cases? In the circumscribed unit, the person who is identified as the first case, whether symptomatic or not, is called an index case or a primary case. The assumption here is that the index case spread the infection to the new cases, also known as the secondary cases. Now, there may be cases in the household that are related to the index case so closely in time that they're considered to belong to the same generation of cases as the index case. These cases are called co-primaries. Index case and co-primaries together are called initial cases. If there are no co-primaries in the household, then index case is the only initial case. Based on the currently published literature, household secondary attack rate for COVID-19 ranges from 11% to 19%. Secondary attack rate has been found to be lower when the index case is asymptomatic. You may have already heard these two terms, case fatality rate and cause-specific mortality rate, in relation to COVID-19 mortality. Sometimes confusion exists regarding the distinction between a case fatality rate and a cause-specific mortality rate. Case fatality rate refers to a proportion formed by the number of deaths caused by a disease among those who have the disease during a time interval. Whereas cause-specific mortality is the number of deaths due to a disease in the whole population, among everyone in the population, during a time interval. If you look closely how these two measures of mortality are calculated, you'll notice that the numerators are the same, but the denominators are different. Let's do a quick calculation of case fatality rate for COVID-19 for the United States. Based on Johns Hopkins University's COVID-19 dashboard, as of October 8th, there were 212,466 deaths due to COVID-19 and 7,589,353 confirmed cases of COVID-19. All we need to do is simply plug in these numbers and we'll get our case fatality rate, which is about 2.8%. Now that you know how to calculate case fatality rate, I'll let you calculate global CFR for COVID-19. Case fatality rate and cause-specific mortality are about measurement of mortality. To measure morbidity, we use incidence and prevalence. Incidence captures the occurrence of new cases in a population of people who are at risk of getting the disease over a specified period of time. Incidence tells us about the risk of getting a disease or infection. Attack rate, not the secondary attack rate, is similar to incidence and is used to measure morbidity in outbreaks and epidemics. Prevalence, on the other hand, captures all existing cases in a population, new ones that develop during the specified time period, as well as those cases that started prior to the specified time period but still exists. Prevalence measures the burden of disease in a population. Now I'll go over the main routes or modes of transmission of infectious diseases. The two broad categories are vertical and horizontal. Vertical means mother to child transmission, whether through placenta, breastfeeding, or during childbirth. COVID-19 has not been found to be transmitted vertically. Under horizontal route, we have direct transmission and indirect transmission. Direct transmission involves transmission through physical person-to-person contact and transfer of infectious agents by droplet spread. Spread through respiratory droplets is the main and the most efficient route of transmission for SARS-CoV-2. Respiratory droplets can transfer the virus while sneezing, coughing, and talking. These droplets are between 5 and 10 micron in diameter and can travel about 6 feet from the source. The smaller the particle size, the further it can travel, and at a certain small diameter, it becomes capable of remaining suspended in the air for a prolonged period of time and can become airborne. Indirect transmission of infection requires an intermediary source. This intermediary source can be a vehicle like water, food, air, or it can be a living insect or animal, which is called a vector for transmission. We've known for quite some time now that SARS-CoV-2 is fomite-borne. What is a fomite? Fomites are inanimate objects like doorknob, countertop, keyboard, laden with disease-causing agents. SARS-CoV-2 can remain viable on the surface from hours to days. We now know that airborne transmission of SARS-CoV-2 is possible. Once again, droplet transmission is the main and the most efficient route of transmission for SARS-CoV-2, not fomite-borne or airborne transmission. Let's now learn about a few important time periods that define particular stages of infection and disease and are pertinent to transmission of infection. First, incubation period is the period of time between the onset of infection and the appearance of symptoms. Onset of infection refers to the time of initial lodgement of an infectious agent in a host. During incubation period, an infected individual may or may not be infectious. Incubation period precedes symptomatic period. Symptomatic period is the period of time when an infected individual is showing symptoms of the disease. It's also known as the clinical period or the clinical stage of the infection. Latent period is the period of time between the onset of infection and onset of infectious period. So it precedes the infectious period. During latent period, an individual is infected but not infectious. Infectious period follows the latent period, and during this time, an individual is infected as well as infectious. Infectious period is also known as the period of communicability. Inapparent or subclinical infection is one where the infected individual does not show any clinically obvious symptoms. Inapparent or asymptomatic infection is different from pre-symptomatic infection, since the latter is followed by the clinical or symptomatic phase. During an asymptomatic infection, if the individual is infectious, they can transmit infection silently to unsuspecting susceptible individuals, giving rise to the term silent spreaders. Although we're yet to learn about the true prevalence of asymptomatic SARS-CoV-2 infection in the population, currently available data indicate that asymptomatic infections make up a significant proportion of all SARS-CoV-2 infected individuals. Serological tests can be done to identify these asymptomatic infections. This is why contact tracing and timely identification of infection and isolation is so important in controlling the transmission of this infection. On this slide, we have visual representation of the 4 time periods that I just talked about. Incubation period and symptomatic periods are connected, and so are latent and infectious periods. However, what matters the most is how these 2 pairs of time periods align with each other, which I'll go over in the next 2 slides. Generation time, which is also known as generation interval, is the time interval between the onset of infection and the end of the infectious period. However, this is typically measured as the time between exposure to infection and the end of the infectious period. And it's particularly important in apparent infection to figure out the appropriate isolation time. Based on the current published literature, estimated SARS-CoV-2 median incubation period is between 4 and 6 days, latent period is between 2 and 6 days, and infectious period is between 4 and 14 days. When the latent period in an infectious disease is shorter than the incubation period, there will be a period of time when the infected individual is pre-symptomatic but infectious. This makes infection control challenging because the infected individual may come in contact with uninfected susceptible individuals during this time and spread the infection. COVID-19 cases can have a latent period that is shorter than the incubation period, so there may be a pre-symptomatic infectious phase. This again signifies the importance of contact tracing, screening, and timely isolation. When we have an infectious disease where the latent period is as long as the incubation period or longer, or the infection is not highly communicable, a longer incubation period is in fact helpful because it gives us more time for screening and for implementation of prophylactic measures. Now, this is particularly important when the microbial agent is highly virulent. For example, rabies infection, which is nearly 100% fatal once clinical symptoms appear. In infectious diseases, where the latent period is longer than the incubation period, there's a period of time when the infected individual is symptomatic but not yet infectious. This will make transmission control less challenging if the infected individual, because of the apparent symptoms, is isolated before becoming infectious. Another epidemiologic term or measure that has gained some popularity because of COVID-19 pandemic is basic reproductive number, or R0. It is also called basic reproductive ratio or basic reproductive rate. So how is it defined? It's the number of secondary cases of infection generated by one primary infected host over the period of infectiousness when introduced into a totally susceptible population. It's a measure of transmissibility of infection. It captures the likelihood of spread of infection at the beginning of an epidemic, when everyone in the population is susceptible to the infection. R0 is the product of contact rate, probability of transmission, and duration of infectious period. Contact rate is the number of contacts that an individual makes with other people in one time period. Probability of transmission is defined as the proportion of contacts which result in transmission if one of the individuals is infectious and the other susceptible. As the infection spreads in the population and some individuals get infected and then recover, the population is no longer completely susceptible. So instead of R0, we then calculate RT, which is the effective reproductive number at time t. ST is the proportion of population that is susceptible at time t. Here, S is the number of people susceptible at time t, and N is the total population. We in fact have ST in R0 calculation as well. But if you recall the definition of R0, its calculation requires a population where everyone is susceptible, which means in R0 calculation, S is equal to N, which in turn gives us an ST value of 1. Different parameters used in the calculation of R0 show that it is dependent on characteristics of the agent, population or the community in which it is measured, and characteristics of the host. R0 is specific to a micropopulation interaction at a particular time. For that reason, whenever we report R0 estimate for a microbial agent, we must always mention the population in which it was measured and the time period when it was measured. On this slide, we see examples of how R0 estimates are reported for different infectious diseases. Here, for each infectious disease, multiple R0s are reported according to population and time. And on this slide, we have R0 estimates reported from COVID-19 pandemic for different geographic locations. If R0 is greater than 1, then the infection is expected to spread because each infected individual generates, on average, more than one new infection. If R0 is less than 1, then the infection is expected to die out. When R0 is equal to 1, a state of endemic equilibrium is reached where, on average, one case results in one secondary infection. One important thing to keep in mind is that R0 is an average value for a population, and there may very well be clusters of individuals within a population in which the R0 could be much higher or lower than the average, leading to a heterogeneous spread of infection. The parameter epidemiologists use to measure whether the spread of infection is homogeneous or heterogeneous is called dispersion parameter, denoted by K. It tells us about the amount of variation in the generation of secondary cases. A K value of 1 tells us that the spread of infection is homogeneous. As K drops below 1, we start to see more heterogeneity in the spread of infection, indicating larger proportion of infected individuals that are either super spreaders or dead ends. For COVID-19, K has been estimated to be around 0.1, suggesting that the majority of secondary transmission may be caused by a small fraction of individuals. For example, 80% of transmissions caused by about 10% of the total cases. Another important concept in infectious disease epidemiology is herd immunity, which is sometimes called community immunity. It's the immunity of a population, group, or community against an infectious disease when a large proportion of individuals are immune either through vaccinations or prior infection. So how does it work? When R0 is greater than 1, if we introduce infected individuals into a population where everyone is susceptible, the infection will spread. Now, if some of the individuals in the population are immune to the infection, then the infection will still spread, but the immune individuals will be spared. However, if a large proportion of individuals are immune to the infection, either through vaccination or prior infection, then the infection, after spreading for a little while, will hit a wall of immune individuals and will not be able to spread any further because the surrounding individuals are immune. This is how a large proportion of immune individuals in a population can indirectly protect the remaining susceptible individuals from an infection, and that's what herd immunity is. The minimum proportion of population that needs to be immune in order for herd immunity to occur is called critical proportion or threshold proportion, and it's 1 minus the inverse of R0. So for an R0 of 2.5, the threshold proportion for herd immunity is 60%. Now, there's no vaccine that is 100% effective. Just to give a quick example, the annual influenza vaccine has an effectiveness between 40% and 60%. The vaccine coverage that is needed to achieve herd immunity is calculated as critical proportion divided by vaccine effectiveness. If, for example, a vaccine is 80% effective and the critical proportion is 60%, then a vaccine coverage of 75% will be needed to achieve herd immunity. I'll wrap up this lecture by sharing with you definitions of 3 important goals of public health interventions that are about the amount of infectious disease present in a population. For most infectious diseases, herd immunity is crucial for elimination or eradication. Even for just control of epidemics and pandemics, widespread and strict disease mitigation strategies are essential. That is all for this lecture. In the next lecture, we'll learn about mathematical modeling of direct transmission of infections. Thank you.